My name is Robert Carlson with Brave Defender Training Group. I want to take a couple moments of your time today, and what I want to talk to you about is part of the TECC or Tactical Emergency Casualty Care programs phases of care, and which is going to be that final phase of care that we call evacuation care. Most specifically, what I'm going to be talking about in the evacuation care is a process that we call triage. Now, triage is a technique or a tool that we're going to utilize in a mass casualty event to allow responding officers to be able to make sure that we're applying the right medicine to the right patients at the right time. So when we look at a mass casualty event, we have to look at what it is we're dealing with first. So first, a mass casualty event is purely going to be any event where the number of patients outweigh the resources that we have available to us at that time. Now, that could be rescuers, that could be equipment, and these scenes can be anything from tactical events such as active shooters or mass shootings to more conventional events such as hazardous materials or large vehicle accidents. It's just any circumstance where the number of wounded patients exceeds our capability to handle that at that moment in time. Our goal when we're trying to deal with these mass casualty events is going to be to maximize the survivability of the greatest number of patients. We're going to try and save as many lives as we possibly can. But what that means is we're not going to be able to save everybody in these scenarios. In a mass casualty event, chances are people are going to die. There's unfortunately nothing we can do to 100% prevent that. So what we want to try and do is instead make sure that we're expending the greatest amount of energy and effort on the patients that have the greatest chance of survival and that we can actually make a difference on. So we do this by making sure that we're treating based upon the individual patient's wound severity, not necessarily the proximity or order that we encounter these patients at. Oftentimes, if we try and start treating the first patients that we come across in a scene, later on we may realize that that was the least injured patient in the entire scene. So what we want to do is we want to make sure that instead of dealing with them in the order that we encounter them, that we deal with it in the medical necessity that's out there. And that's going to allow us to make sure that we're evacuating those critical patients first. And instead of wasting ambulances and EMS resources by transporting minor injured patients, again, we're getting those ones that need to get to the trauma center as fast as possible. We're getting there in that rapid, expeditious manner. So how we accomplish that is a process called triage. Now, triage, by its very definition, the word means to sort. And that's exactly what we're going to be doing, is we're going to be sorting these patients based upon their wound and severity type so that we're expending that greatest energy at the percentage of patients we can make the greatest impact on. This is going to take into account each patient's injury type and their wounds, as well as what their possible survivability outcomes are. Again, because we know we can't save everybody, we don't want to be wasting energy and effort on patients that have no chance or minimal chance of survival. We want to make sure that we're expending that energy and resources on patients that we can actually make a difference on. So this is going to give us a framework to make sure that we're prioritizing those finite resources, such as time and manpower and equipment. Those are all things that are going to be in very short supply in a mass casualty event. So we want to make sure that we are using all of those things appropriately and in the most efficient manner. And this is going to give us a framework to make some very complicated and very stressful medical decisions. There's going to be a lot of decisions that we're going to have to make, and this is going to give us a framework to make those on instead of trying to base them on emotions that we may be feeling at the time. So the overall premise of handling this mass casualty event and doing triage is we're going to take that March algorithm that we've talked about previously, and instead of applying it to an individual patient, we are now going to take that March algorithm and we're going to apply it to an entire event where we focus on all of the massive hemorrhaging first, and then we move on to compromised airways, and then we move on to sucking chest wounds and penetrating trauma that's compromising the respiratory system, and then circulation, and finally that head injury and hypothermia. We just simply take and treat the entire scene in that March order of treatment. So the system that we're going to use to be able to sort these patients by their type and do an effective triage is the standard EMS color coding system. This allows us to manage and organize their patients by the level of care that they require and gives us a visually recognizable indication as to which patients are going to require the greatest care. So the triage color code system that we're going to use is going to be red, yellow, green, and black based upon the patient's severity and wound typing. So our red patients are going to be anything that we categorize as immediate. These patients have life-threatening injuries that require immediate intervention. They may only have minutes left to live if we do not provide treatment to that wound. Yellow patients are going to be those that we call delayed. They have serious injuries, however, those injuries may not be immediately life-threatening at this moment. However, they do require care and they require constant observation to ensure that those wounds don't continue to get worse and possibly slide them into that red category. So when it comes to level of care and when these patients need to get evacuated, these patients may have hours before they expire. So we have a little bit more time with them than those red category. Our green patients are what we categorize as minimally injured or what we would call walking wounded. These typically, these patients have non-life-threatening injuries. They're very minimally wounded. We have an extended period of time with these patients before we need to get them to a higher level of care. And then our black category is going to be any patients that we categorize as expectant or deceased, meaning that we expect them to die or they are obviously already deceased. This just simply means that we are unable to treat whatever injuries they have. They are so extreme that we are unable to treat them with the resources that we have at hand. And so rather than wasting time and resources when this patient is likely going to expire anyway, we're going to move on and use that time and those resources on a patient where we can actually make a recognizable difference, such as in the red and yellow categories. So some examples of wounds that we may see in each one of these categories is going to be within that red category. Any wound that falls within the first 3 steps of the March algorithm. So any massive arterial bleeding to the extremities, any airway compromise, or any injury that has compromised the respiratory system, such as penetrating trauma to the chest or causing a sucking chest wound or tension pneumothorax. So anything that falls within that M, that A, and that R of March, we're going to categorize as a red triage level. Yellow is going to encompass, again, serious injuries, but those that aren't immediately life-threatening. So this can be possible eye injuries, major burns over large parts of the body. However, those that aren't affecting the respiratory system, such as like the face and the neck, abdominal wounds or penetrating trauma to the abdomen, major bone fractures of large bone groups, or venous bleeding. Now, venous bleeding can have a large amount of blood associated with it, but because it's not arterial, it's not that immediately life-threatening like we would see in the red category. And then green, this is going to be, again, those minimally injured. So this is going to be your cuts, scrapes, abrasions, minor bleeds, maybe joint injuries such as sprains, things of that nature. These are just those non-life-threatening injuries that we don't want to focus on immediately because we have greater problems to deal with. And then within that black category, this is going to be any obvious signs of impending death or possibly patients that have head injuries that are also unconscious. Because we don't have the ability to do a patient assessment, it is simply going to require too much time and manpower to treat that and do a patient assessment that we don't have in a mass casualty event. Or a patient that has large multi-system trauma and multi-system organ failure. These injuries are so extreme that it requires more resources than we have at hand. So rather than tie up manpower, time, and resources on a patient that is likely not going to live anyway, we're going to move on and be able to apply that effort to a patient within that red and yellow category where we can actually make a recognizable difference. Now, one of the things that we can do to make our life a whole lot easier in a mass casualty event is going to be consolidation. That triage process can be extremely difficult when we have patients spread throughout an entire scenario. Depending on the size of your structure, I want you to visualize like a school or a mall or some sort of large structure. You can see how difficult it could be to triage these patients across that entire structure, and then realize that your more serious one was 10 rooms back. So one of the things that we can do to make our life a whole lot easier is let's get all of our patients, let's get all of our problems together, and let's put them in one centralized location. This is going to actually speed up our treatment process as well as enhance that triaging system, because we're able to view all of our problems at the same time. It's going to maximize fewer rescuers. By having everybody in one location, we're able to treat more patients with fewer resources by everything just being co-located. And it's going to allow us to ensure that the right patients are receiving treatment in the right order. So consolidation is one of those highly recommended practices that we can do to make a mass casualty event in a triage system a lot faster and a lot more effective. Once we have all of our patients consolidated, we call this a casualty collection point. So we want to make sure that once we bring all of these patients together into that CCP, that we're choosing that location appropriately. This is going to be a centralized casualty collection point. So somewhere where we can easily get all of these patients to. Think about how you're going to be getting these patients out of the building though. So we want to try and make sure that we place that casualty collection point within some sort of close proximity to the exit that we're going to be using to get these patients out. That'll just speed up that evacuation process. We want to try and minimize moving as many patients as possible. So if we have one location that has the maximum amount of patients, probably makes a whole lot more sense to set that location up as your casualty collection point if it's feasible, so that way you're only moving a smaller number of patients. Now, in a tactical scenario that is oftentimes encountered by law enforcement, such as an active shooter type of event, because we may still have clearing operations going on inside of the crisis site, we need to think about being able to defend and protect this casualty collection point. So in a tactical scenario, we do not recommend establishing your casualty collection point outside of the building because it's very difficult to defend that, and you may have people coming and going without your knowledge. We want to try and avoid putting it in hallways. So try and find a room that is going to be large enough for you to place all of your patients, and it's going to be easy for you to put armed officers at the doors and defend it. Once you have that casualty collection point established, somebody needs to step up and start acting as the casualty collection point or triage manager and get control of this event. So somebody needs to take ownership of that casualty collection point and start directing where all of the patients are going to go. And one of the things that we can do to make this casualty collection point a lot more effective and a lot easier to manage is a process that we call geographical triage. So what I mean by geographical triage is we've already talked about how we're going to triage our patients by color coding. Now we're going to organize our casualty collection point by those color codes. So I can take all of my category red patients and place them on one wall. I can take all of my yellow patients, place them on another wall, and all of my green patients and place them on a different wall. This keeps us from stepping over people and trying to find a patient and running around in just total chaos. All of our patients are spread throughout, and now as I get more rescuers in, it's easier for me to direct how many people I need treating each level. And as EMS arrives on scene and they're looking for what patient to go out first, we're not running around and hunting. We simply just grab off of that red wall and start pulling patients out in that order. And then we can take all of our medical resources, all of our medical supplies, and simply pile them up in the middle of the room so that as we need something, we're not running around hunting for who has it. All of those medical assets are going to be located in the center of the room. So geographical triage is one of those easy ways, and I promise you, if you implement this, if you ever find yourself in a mass casualty event, it is probably the best way to truly gain order out of that chaos and organize all of the things that you have going on. Now, final consideration as we talk about mass casualty events is going to be CPR. Oftentimes the question gets asked of, do we do CPR on patients in a mass casualty event? And unfortunately, this is one of those things where a patient that requires CPR is going to be categorized in that black category. We are not going to be doing CPR on patients in a tactical mass casualty scenario for a variety of reasons. One, CPR has been proven to be very minimally effective in tactical trauma events. It has a very, very low success rate on trauma patients. So it's not going to be worth the effort and the manpower that we're going to be devoting to it. It's also very time consuming, and it ties up manpower because once we start it, we're stuck with it. And when time and resources such as personnel are in such short supply, we cannot afford to have those tied up dealing with one patient that truthfully has such a low survivability outcome. So these are the steps that we can do in a mass casualty event to get better control. We start that triage process and identify our most critically injured patients first. We identified based on the wound category, those red, yellow, green, and then black patients to allow us to focus our medical efforts on the patients where we can make the greatest impact. Understanding that our goal is not to save everybody, it is to save the greatest percentage of people. And we can have the best effort in doing that by doing that patient consolidation. Getting all of those patients together to one location to allow us to visualize all of our problems at once is going to make it a whole lot easier to do that triage system and then to apply that March algorithm to all of your patients simultaneously so that we make sure that we are checking off all of the massive arterial bleeding on all of our patients before we move on and are starting to treat lesser injuries somewhere else. We want to make sure that we're treating the most serious injuries first across the entire scene. If you have any questions, please don't hesitate to contact us with any issues that you may have. Thank you for your time.